Hi everyone, welcome to today's seminar. So today's speaker is a special guest, Rishi Ramakrishnan. Rishi is actually an alumni of ACFR. He did his PhD here at 2016, and afterwards he did a postdoc here as well. And today he is head of product development at Baymatob, which is a medical device startup that aims to improve health outcomes of mothers and babies. You can blame Rishi. Oh, and by the way, feel free to raise your hand, ask questions during the talk.
Awesome. You're right here, right? Yeah. Okay. Yeah, so good afternoon, everyone. So as I said, my name is Rishi Ramakrishnan, head of product development at Baymatob. So I'll give you a bit of an introduction into, I guess, my history here. Yeah, back in 2007, 2011, I did mechatronics engineering and science, and did my thesis with the group that was here at the time, which is the BAE Center for something, BAE Sims, I think it was. So I did a lot of like urban and semi-urban classification of images and image sequences. So like, as you guess, times have changed between 2011 and 2000 and whatever we're in now, 2023. So this was using more of the old SIFT classification things, so like extracting feature points in an image, describing the high-dimensional vectors, and that was kind of like state-of-the-art kind of things at that time. And yeah, things have just taken a turn for a bit of a different classification of things now. So after that, I did my postgrad between 2012 and not 215, but 2015. So that was over at the Rio Tinto Center for Minor Automation. So I did that with Steve Shedding and Juan Neto. And so that was more about illumination, variant outdoor perception. So getting rid of shadows, getting rid of like indirect illumination in images, in hyperspectral images, using that kind of a fused approach, using LiDAR images or LiDAR fused with hyperspectral images. And the aim there is like kind of just to improve your classification by removing these illumination artifacts that can occur in the outdoor environment. After that was a postdoctoral researcher here for a little bit. So we worked with the Agency for Defense Development, South Korea. So that was with Dave Johnson. And we're working on like multi-modal classification again and a semi-supervised learning approach. So you take your vehicle into an unknown environment where you don't know what all the objects are there in the environment, and it's being able to do the classification, learn what the new objects are, and then how do you go and classify those objects after that. After that, I then kind of left and we came to Baymatob, so it started in 2017. My role is head of product development. In reality, it's machine learning engineer, software backend engineer, and head of product development. Kind of in startups, you have such a small team that you need to do basically everything. So it's, yeah, I'm still not just like a high level person. I'm still basically holding the team up by not doing my work and not doing the software at the moment. What I want to talk about today is how do you go from kind of a research or academic development of some kind of device that you might be doing in PhD or in postdoctoral researching, and how do you go and take that into a real world commercial product development environment, and more specifically for the medical device industry. So going from something that's put together on a phone case to putting together a card computer and getting onto like Channel 9 with Peter Overton last night. I don't know if any of you guys watch Channel 9 News anymore, but we were on that last night. And it's Peter Overton not looking very good, but I'm sure he enjoyed it. So I guess what's the first thing that you've I don't know, is everyone here like postgrads or postdocs or
mixture?
A bit of a mix here. Yeah, okay. So I don't want to offend anyone, but as an engineer, and I don't want to generalize all engineers, but engineers are really good at like identifying solutions and then trying to abstract the solution to every single problem. And one of the key things that I think I found that over the years is that it's better to get the reverse, right? So identify the problem first, and then whatever your solution is, then to come back and see what's the applicable solution there. So the first thing we're looking at here is trying to understand what the problem is. And Baymatob started when Sarah McDonald, founder, had a traumatic birth experience, and where she was attached to industry standard medical devices and left for quite a long time. And basically clinicians didn't understand what was going wrong or anything like that. And that is the limitation of the current state of affairs. So when you go into a hospital for basically before labour and during labour and giving birth, you're attached to basically the industry standard CTG here, which is basically two large straps that are wrapped around your body, and you're immobilized to a hospital bed connected to this large machine. And that's basically your clinician will come in, observe, look at that trace for a little bit every sort of like 10 minutes, every half an hour. Then they'll make an assessment as to how you're progressing in labour. And separate to that, you've got things like the fetal scalp electrode, intrauterine pressure catheter, which is not used in Australia because it's highly invasive. And recently we've got more up-to-date EMG, ECG kind of devices, but they're not really used. So what are the limitations to this? Well, A, you can't let the mother is not able to experience their desired birthing experience. They're tied to a bed, they can't move around, they can't walk around. Usually hospitals they develop their policies so that everything's more beneficial for the clinician as opposed to the mother. And this is not great because doing things like movement, being able to go into water and things like that aids in the progress of labour and the whole experience. So first of all, what's a CTG? So to break it down into like particular sensors, well then the CTG is basically a strain gauge. So the strain gauge basically, it's pressed against your maternal abdomen. It goes in and out as you have contraction. And basically the output you get there is this kind of curve that's going up and down, up and down, up and down, and indicates, okay, here that person's had a contraction, they've had a contraction but hasn't come back to the base tone, so they're having what's called coupled contraction. And this is what people use to measure labour progress. So this CTG has been around since the 60s, and nothing has fundamentally changed with the way labour is actually monitored over time since till now, 2023. The same fundamental data is being measured. So you've got this idea of uterine activity, you've got fetal heart rate, you've got maternal heart rate, and basically you're looking for, you've got a contraction. Is there a variability in fetal heart rate at the same time? But we all know, like, if you took a different sensor to that, right, there's more happening under the hood to that. That's just a very overarching envelope to what's going on. And so the measures that they kind of use at the moment are things like contraction duration. So how long was a contraction? And then that's basically converted to, this is a strong contraction, this is a mild contraction, it's a weak contraction. And that's just based on time. You've got the interval between contractions, you've got the peak of a contraction, and you've got the contraction frequency, which is how many contractions are occurring every 10 minutes. And the fundamental thing that's wrong with this is that it doesn't actually give you a lot of information to make clinical decisions. So while there's rough things you can get from this, it's not saying is the labour progressing well? Is it progressing? Do I need to intervene? Do I need to give some drugs to speed up labour? It's fundamentally not doing its purpose. And the longer you have a CTG on, the higher the chance of a false positive, then the more chance that someone will unnecessarily bleed. So currently, the World Health Organization kind of says what we should be striving for is a 15% cesarean section, and what we've got at the moment is probably around the 30 to 35%. So there's a lot of unnecessary births going on. And this is what's happened over COVID time as well. Changes in hospital policy have led to more interventions. So we've had higher rates of postpartum hemorrhage, higher rates of cesarean sections over that COVID period due to changes in hospital policy. So with that in mind, we then come to like, what are the underlying physiological signals that are trying to be measured? So the underlying ones, things like maternal heart rate, fetal heart rate, uterine activity. Things like fetal movement is also there, right? Maternal movement as well. And how do you actually measure those signals? Can anyone give me like an idea of different sensors or anything that you might use?
Ultrasound.
Ultrasound is one that's commonly used for heart rates, fetal heart rates, and fetal movements, actually. Anyone else? Yeah, excellent. EMG, ECG is also a really, really good one to use to monitor like underlying biopotentials and things like that. Kind of you can use to monitor these physiological signals, and that's like the how they can be measured, right? So what Sarah did in her PhD when she was working with RPA and ACFR is get like a proof of concept device that has a few of these different sensors, take it to RPA and do a few pilot studies on around 86 people. And this is basically, I don't know, you guys probably played around with Arduino boards and stuff like that. So essentially Arduino boards and little PCBs chucked inside a phone case that's basically attached to the maternal abdomen. And that's been sufficient in order for us to determine what sensors can be used and what are the locations at which they can be used. So in this one here, what we're looking at is where can you actually place a sensor in order to correctly monitor or actually to detect underlying physiological signals. And what was found is that we don't need to go down here into kind of the lower maternal abdomen, which is actually where clinicians are usually using other devices. We can actually remain up the top on what's called the fundus. So that remains out of the way of other devices, while at the same time still getting the same amounts of data. And what we also look at this is what sensors could be used and kind of a bit more understanding of what kind of set frequencies, what kind of resolutions of that data we'll need. Now, the key thing that comes next is there a commercial need for a new device, right? If the answer is, let's make another CTG, there is actually no commercial need for that because clinicians don't want another CTG, or even if it's wireless, they don't want that. So what happened was Sarah went and did the medical device commercialization training program. So this is over at Cicada in the carriage, wherever. What is it? Carriage Works? Yeah, Carriage Works. So that's like run by the New South Wales. That's run by the New South Wales government, funded by I think New South Wales Health, and has a lot of government ties in there. I think there's like similar ones that some of you might have done, which is like to do with agriculture and meat and livestock Australia. I think there's new ones coming along, which is physical sciences is a new one.
It's kind of
yeah. And so these training programs are all about helping you to kind of identify what your commercial need is. So you go and do a lot of interviews with stakeholders. You fill what's called a business model canvas to understand who are the key partners in your area, what are the activities, resources, what's the value that you're actually providing, and who are the customers, things like that. And so from that, it was decided, yes, there is a commercial need for not just a new CTG, but a new medical device in the pregnancy and labour space that could actually generate new information, new more objective information that a clinician can use to make more informed decisions. So this whole thing is overarched by the idea that we want to reduce unnecessary interventions to mothers and that sense. And so Baymatob started, we were a team of 3 at that time. And we went and we generated what we call the Ollie Mark 1. So the Ollie Mark 1 is basically just this. It's a multi-modal sensor device that's placed on the maternal abdomen. It was talking to what we call the catch, which was a watch. So smartwatches had kind of just really come to the forefront at that time period. So, we were jumping all over that. We're going, smartwatches is the way to go. They're going to have a lot of computation. They're going to be really nice. Everyone likes wearing watches, right? So, and basically it just transferred it measured signals using its sensors from the device, transferred it to the watch. The watch stored it. We would take it. We would use some random shell scripts to download the data to a hard drive, and then would come back and analyze it on our local machines. So a lot of moving parts there, and a lot of problems. So we went and did some field trials with that device and that whole setup there. We went to a horse farm in Victoria. So it was a stud farm where basically they have a lot of foaling mares. And we also went to a farm in Queensland that had some camels. And so like the underlying physiological kind of idea of having, there's a uterus and there's a baby inside is kind of there for both of them. And you're just attaching the device outside it, so you should be able to measure that signal. So this is a good kind of time to basically get comparative physiological data from different subjects and do that during the pregnancy and labor process. And secondly, this is the first time we're getting that device out, is to assess the usability and functionality of that device. So a lot of fun was had here in terms of not getting kicked by horses or camels, and in terms of like getting that device stuck on a horse, which is likely to, go and sit down. Camels like to roll around, things like that. And we learned quite a lot from that. So what did we learn? It's electrode adhesiveness. So these things here, these things here are electrodes. So you've got to get them stuck onto the subject, right? Horses, camels, they have a lot of hair. So, we needed to actually shave small patches into them. And then they sweat quite a lot. And, we sweat, animals sweat, and the tappiness of an electrode is then compromised, right? So it's going to fall off. It's going to lead to a few of these devices just falling off. So ended up needing to use sports tape things to basically attach that firmly to the horse and camel. It was the first time we were doing a lot of software. So we actually, I forgot to mention. So this design we had outsourced to a design house, and they actually generated that from our own clients. In saying that, we then had a lot of wireless communication and software bugs. So I don't know if you guys remembered that, but during COVID, the New South Wales government had that application that you could put on your phone, and you left it running, and it would tell you did someone with COVID come near you. And there were these issues with it, right? There was it wouldn't work if your device was locked or something like that. Exact same problem that we had, because we're all both using Android systems, and getting the Bluetooth on an Android application to work while it's unlocked is not the greatest thing in the world. It's pretty difficult to do. So I was sympathizing with those software developers who had actually made that, because it's quite a hard thing to do. So we had a lot of communication dropouts and lack of reconnection between the watch and the device there. The third major thing that we learned is the value of timestamp integrity, right? So you need to understand kind of precisely what your underlying firmware of your PCB is doing. Because if that's having some issues where it's, maybe its clock frequency is running too slow, maybe it's every time it fills up a buffer, it then crashes and makes things hard, then you can't precisely timestamp things later on. And if you hold down the watch, it turns out, if you hold down the button on the watch, it resets to January 1990 or something like that. So we had like data that, it's looking good, and then it just reverts back to 1990. And so we needed ways of actually dealing with that. Well, animal temperaments, these are horses and camels. You've got to be careful with them. There are several times when I've been like waiting for a camel to come back to its to what's called a camel crush, where it's situated between two metal things that keeps it stable. And suddenly, like the reference electrode would fall off 2 meters from the thing. It would then stamp on the reference electrode, pull out of the device, break the whole thing. And that's not fun for anyone. You need to be able to like trace where your data is coming from, right? There's no point taking a robot out of the field if you don't know what it's actually measuring, where was it located, which robot's actually doing the measurement. And so having that traceability between the subjects and the devices is really important. And because you're just dealing, there's no user input on these watches, you don't really have that idea that this watch belongs to this horse. And ultimately from this whole thing, we generated some prototype algorithms to show the feasibility of sensors of product and the product. So from this, we developed a algorithm for predicting the time to birth of the horse. And that, while we say it's between 60 hours, like plus or minus 60 hours, doesn't seem that great, right? To I guess you guys as robotic engineers, but when you compare it to the actual standard of care that a farmer has, they're looking at an accelerometer that basically gives them false positives when the horse lies down, because the idea is that when a horse lies down, they're ready to give birth. And so they have about a 2-week period in which they think the horse is going to give birth. And we were basically trying to reduce that down to a number of days. In terms of business learnings, there was a lot of things we had to learn there. So we needed our internal capabilities to expand, because we've outsourced everything to a design house. We need to bring that internally in order to actually just boost up our knowledge and make sure that the product is being driven to something that we want it to do. I've never heard of a QMS. Has anyone else heard of QMS? Yeah. So it's like you guys who, you might have just come from undergrad, you might have been at startups and stuff like that. The idea of like a quality management system doesn't really exist until you get to particular businesses. And this means like you've got documented standard operating procedures, work instructions. You can't change a document without, putting a change order or something and getting it approved by 3 different people. And in the medical device industry, you need to be certified for particular standards. So there's one famous one, it's I3, 13485. It's like a medical device development one. You need to have your software certified to a particular standard. So gone are the days where you could just do a git commit and push it and go, yeah, that's working. It's doing the unit tests. Maybe you submit a pull request. I don't know, but you can't just do that when you're following an actual software development process. We expanded our team to 5, basically because we needed the internal capability. So we added a firmware engineer, a quality manager, and an engineering intern from UTS. And we made this decision to bring the whole design in-house. So then we expanded again to 12 by bringing in different engineering, so mechanical, electrical, added more quality, brought in CRO, added an administration person, basically just keeps us all together. And this then led to the kind of the next generation of Mark 1, where we still have the same patch and the catch, but we've added like a user interface to assist in that traceability between a subject and a device and the time at which they'll monitoring. And the purpose of actually creating that is because it's no longer a technical engineering person running a shell script. It's going to be a midwife or a clinician who's actually downloading that data, and we can't expect them to run shell scripts and things like that. And basically, this then saves our data to what we call the data box, and as a backup to another hard drive that we can bring back to premises. So this thing here was used in a pilot study. We conducted it at 2 hospitals in New South Wales, and it's quite a large, it's not a large human, it's a lot of people pilot study that commenced with like subjects split into 3 groups. So I'm only specifying 2 groups here, and that was the 1As and the 1Bs. So this was an antenatal one. So antenatal means you're monitoring during pregnancy, so we were monitoring from 36 weeks. And the 1As, they were monitored alongside CTG, so we can get comparative data between the early device and CTG. And back, a few years ago, antenatal monitoring, you'd come in once a week, and you'd come in for, you go to the hospital, they'd sit you down, and you'd get monitored. The idea with the 1Bs was that we'd have repetitive antenatal sessions. COVID kind of hit, and that meant people don't really do weekly ones anymore. They were doing more remote. So our numbers in that kind of dropped. So the learnings we got from that antenatal kind of monitoring was that water use was going to be really important for in-labour monitoring. And the issue with our device at that time was that it was not waterproof. It was very difficult to reliably and robustly assemble it. And that was not going to work when we did the in-labour monitoring. From this data, we also had some initial algorithm development on maternal heart rate. So what I'm showing here is in blue is the maternal heart rate generated from our device, and it's overlaid and time synchronized with the outputs from CTG. So they match very well. And so that was a good initial development. Knowing that we wanted to go to in-labour monitoring, we had to make some changes. And so that led to the Mark II. So the Mark II was basically the same setup, but an upgrade to the actual device. So on the one we have here in the left, a lot of areas where you could have water ingress that comes in PCBs, maybe a shorts or maybe a road or corrodes the PCBs. We had a really long reference way because this was actually designed for horses and camels. So the reference way was like 1 and a bit meters. So if you're attaching that to a human subject, you've got to coil it, you've got to tape it up, and it's pretty uncomfortable. So by bringing all our capabilities in-house, we then designed the Model 2 of the device, where, like you can see, the button is now a one-piece overmolded structure. We reduced the cost of the assembly by about $160 by in this one there were these little patches here that were glued in with Sikaflex, which you can get from Mitre 10, and each one of those is like $40. And so now we're going from making 1 or 2 devices to making tens of devices. So we need to increase the robustness of that assembly. And inside there's also 2 PCBs previously held together with ribbon cable. Now they're actually sandwiched with a different connector just to improve that robustness. So we've used this one in the same pilot study, but we've added this group here, which is the in-labour group. So in labour, you're monitored usually for high risk. Generally, you're monitored continuously for high risk births, and that definition of high risk has actually changed over time. So basically, a lot of people are getting monitored, and that's in conjunction with CTG in a lot of cases. So from this in-labour monitoring, we then went and did maternal heart rate in labour. We were looking at uterine activity, so looking at contractions and movement underwater. And we developed what's called a postpartum hemorrhage prognostic. And I'll discuss that a little bit later. And we also then realized that we needed a much needed software update / overhaul, because we needed to replace the catch, the watch, and that fetch system with a completely different architecture. So the postpartum hemorrhage prognostic was developed based on the initial data that we got from that pilot study. We were looking at different features, and how they changed over time, and whether they could indicate that a postpartum hemorrhage was going to occur. And this then led us to go down a particular regulatory pathway where we looked at things, looked at FDA and got designated as a breakthrough designation. This then leads to a whole bunch of expansions. Now we're then expanded to 22 people. And from this, we need to re-understand
breakthrough designation.
So yeah, I'm not a regulatory person, so I'm going to get something wrong.
Yeah.
So when you submit a device to FDA, you need to show its performance. So there's a number of ways you can do that. If you're doing the same thing someone else is doing, you can do what's called a 510K. So you can compare your device against another device, show that they're either similar or you're much improved. There's ones called de novo, which is your brand new, I think, and you need to show something. You need to show good performance, or you need to show clinically beneficial performance. The breakthrough designation allows you to streamline that pathway and get a lot more help from FDA if you have a device that is doing something brand new, basically. And that's, I think probably Cochlear and ResMed probably did the same thing, because they basically create their own pathway. So if you went and did a sleep apnea machine, I think they did.
Right.
You do that right now, you need to actually, ResMed has actually designed standards you now need to follow. So if you do a breakthrough designation, if you get this application, you're basically setting for what everyone else needs to do in the future.
Okay.
And so what we can do now is we need to re-understand what the actual problem is, because now the problem is not we need a new monitoring device. It's we want a postpartum hemorrhage prognosis. So postpartum hemorrhage is the leading cause of maternal deaths globally at 11%, and it only gets diagnosed after the event has occurred. So someone's having a bleed, they then afterwards they measure the amount and go, okay, you've got a postpartum hemorrhage. And so there's a number of different causes for that, and there's what's called the 4 T's: atone, thrombin, trauma, and something else I forgot. And atone is the most prevalent one, which is where your uterus is no longer contracting enough to put pressure on put enough pressure to stop that bleeding of the uterus. Mortality rates have shown no improvement over the last 40 years, and that prevalence is actually increasing. And there's also this idea that 54 to 93% of these maternal deaths due to obstetric hemorrhages are believed to have been preventable by being ready for that and by having the different drugs and different devices ready after that bleed is occurring. So we do things a little bit different, quite a lot different in Australia. We're actually pretty lucky. So yeah, okay, cool. In Australia, we give we try and do a lot of preventative injections prior to delivery of the baby. In somewhere like America, where there's a lot more commercialization thing of the actual hospital process, they don't have a lot of what we have in Australia. So they have a much higher rate of postpartum hemorrhage. And in fact, they've actually changed their definition to go from a greater than 500 milliliter bleed in Australia is postpartum hemorrhage. In America, they get away by saying greater than 1,000 milliliter. And that's why a lot of reported postpartum hemorrhages in America is actually a lot smaller than you expect, because they're just not measuring below that. So what we did is what I like to call the Mark 2.5, where I've replaced the watch and that fetch application with just a laptop, and that kind of just removes the idea of user input for subject IDs and things like that. It makes that a much more streamlined process. From that, we had like an improvement in communication between. I'm calling that laptop a terminal, by the way. We have a much better improvement in communication between the patch and the terminal. We reduced our dropouts from between, I think we were averaging about 17% down to about 3% by just having a a better hardware and a better software. We reduced user error by removing that user input. And we also got a lot of feedback on our electrode design. So these were our electrodes that we were using. We started off with these ones here. You've got 5 individual electrodes that connect onto the device. We then have moved towards this idea of a sheet. So it's matched up with the device to make that attachment easier. And then we've added things like tabs to make the removal easier. And that's all through basically just listening to the clinicians who are actually using it, understanding where those pain points are in terms of cleaning time of the device, which is directly reflected with the adhesives that you use, and also the attachment time. From this pilot study, we basically continued to do further work and develop postpartum hemorrhage prognostic. So a prognostic is what you do beforehand. So a diagnostic is what you do afterwards. Maternal heart rate, uterine activity, and also fetal movement. So fetal movement is part of our longer term strategy in terms of trying to get towards a stillbirth prognostic. We've now moved towards what we call the OLLI Mark III, and big changes here. So we've just got the patch. There's actually no watch anymore, and it goes straight to basically this idea of a terminal, which is a computer on wheels with a charging dock, and that just uploads to the car. Later on, that then gets integrated into hospital systems to send the information directly to them. We're going for larger scale manufacturing assembly. So we're going from tens of devices to hundreds. And I think one quote that sticks with me during my postgrad thesis with, I think it was Steve Chetting, who says, like, if you can show your algorithm on one data set, you've got an undergrad thesis. You show it on 2, you've got a master. You show it on more than 3, you've got a postgraduate thesis. And similar thing here is like we started off with those Mark 1s, which are maybe less than 10 devices. Went to the Mark 2, maybe 10 to 20. Now we're going from like this idea of tens of devices to 200. So the manufacturability of this becomes really, really important. So being able to assemble, manufacture this at higher scales, you've got to change your design quite a lot to do that. You've got to be not cutting costs, but increasing the quality, which maybe you take it into cost, but you've got to have good suppliers, you've got to have good work instructions, you've got to have good testing to identify problems early in the assembly process. And so that's what's happening with the device there. The terminal has completely changed. So we've now got this idea of a cart. It's an off-the-shelf cart that we then attach our charging dock to. We've got our off-the-shelf computer running our software on it as well. And we've started to develop this user interface here. And we've taken it into hospitals, started using it there to get feedback on how it's actually being used. And it's working a lot more streamlined than using going back to the days of the device and a watch and things like that. From this, we'll be able to compare a lot of our visualizations to time-synchronized CTGs, looking at what does a contraption look like between the two, and trying to get clinicians into the process of moving away from the idea of a CTG to using more underlying features that could be useful for things. We have a pivotal clinical trial coming up for the postpartum hemorrhage prognostic. It should be the end of this year. I mean, yeah, I say end of this year, might be end of this year, beginning of next year. It's on more than 450 subjects, and it's in both USA and Australia. So when you submit to FDA, they obviously want some US data, and you've got to show breakdowns in terms of race and age things. It's got to be appropriate for the clinical population. And so what they push is for a lot of the data to come from the US. And once you do that, that then makes your TGA, so TGA is the Australian body, it makes their application bodies, because they tend to follow what FDA does. After that, we're not even ready for sales, because you need 2 or 3 other clinical trials for the different other capabilities of the device. And then because we have breakthrough designation, we can start selling that, and then we need to do a post-market surveillance. So after it's sold, you need to track how things are going and do like an outcome study or something like that to show even more benefit. We need to also do premises shift. So we're up in Leichhardt at the moment, probably move around somewhere to the US, but we need to basically expand from about 22 people to about 55 to 100 people over the next 2 years. And we need a place where we can do design development work. We want to do manufacturing and assembly in Australia, because I think it's nice that you have that manufacturing assembly capabilities here. You can keep an eye on things. You can make sure that things are remaining ethical and sustainable for your business, and you don't get into an issue later on where you're trying to pay money to try and like fix past problems. It's better that you don't have those problems in the first place. And yeah, we need to do a lot of expansion, get more engineers, we need to increase our software team, our machine learning team, basically all our team, to be honest. Are there any questions?
Yeah, if anyone has a question, feel free to raise your hand online as well. I'll call them out.
Thanks for the presentation. For your placements, because of the vascular structures, do you have any variations if you place it in a central place as opposed to somewhere that might have some placement?
So the question's on placement of the device. So I think initially we're just looking at, it should be symmetrical around that central axis, and it could be down here, it could be lower. You get different signal strength of the different. So if you're doing maternal heart rate, right, you're going to get a lower signal size ratio if you move it down as compared to above. But you might get you'll also get a different type of uterine activity, because a lot of the muscles are from up here. So but that signal size ratio changes. So we've played around a bit with moving it along that central axis, but we don't really like to go either way. The reference electrode is really important because you want to kind of separate the electrical ground plane from what you're measuring, and you want like a neutral one. So on a rib or a hip is like usually the best ones for that.
Because of the inpatient time, we have issues with biovalve for a while as a
So is that like a cleaning?
Yeah, like the stuff.
Yeah, but so like at the end of labour is tends to be a bit messy. So you get some I guess bodily matter on that. It's just a matter of cleaning it. Where birth is not a sterile environment and doesn't need to be. And so basically we just have procedures to clean it. During COVID, we also had to add like an antivirucidal wipe as well, and then do another clean on it. So we don't really have, and with the electrodes, they're quite stuck to the subject, so you don't get bodily fluid going in and conducting with the hydrogel, which is the one conducting in the stick.
Any other questions?
Maybe I have a general. So it sounds like for this kind of device, because there's so many kind of regulatory steps to go through and so on, there's quite a long development time before you can actually start selling things and bringing in revenue, right? So I don't know. I mean, maybe I don't know how much of this you can speak publicly about, but what's the kind of investor model that you have? Is it are you basically working on kind of investor input at the moment? Are you getting any funding from like the hospitals that are trialing the work? Like, are they paying anything to support the trials, or is it all from kind of external investors? How does it kind of work on this development pipeline?
Yeah, so probably should be a bit more clear. When I mentioned the medical device commercialization program, one of the outcomes of that is we end up getting funded by the New South Wales government from a grant. So that's called the MDF grant, so that's Medical Devices Fund.
Okay.
They funded the first few. So it's a non-equity diluting thing. So it's basically a grant. And once you start making revenue, you'll start paying at that. So we got that during the first two years, and then we applied again. And so to get that second application, you have to have two people do that program. So I did the second one, and then we'll get funded again after that. And then we're going to get private investment after that. So that's now funding us. And we're currently in the middle of getting more investment to take us past the clinical trial.
Right. So mixture of investment and government grants.
Yeah. I think generally being at this stage is good because you can kind of choose that your investors have similar ideas and concepts. So we can choose to be really picky about who is investing, whether they're driving it towards what we don't want, which would be like a pharmacy kind of device that can take home. Like we want to drive it towards just a purely hospital-based clinician prescribed kind of,
right?
Because it's not meant for home function.
So the idea would be ultimately it's the hospitals that are purchasing this product.
It's the hospitals and like private hospitals.
Yeah.
More that I tend to stay clear of like business side because I don't really like that kind of things. What we drive towards is a hospital prescribed or obstetrician's prescribed dose.
And is the model like you sell the product and it comes in a box and got all the software and stuff like that, or are you selling an ongoing service to provide?
It's
the
more of a
analysis?
software as a service
kind
of thing. So when you generate new algorithms and stuff, you could subscribe to that, like the hospital pay.
Yeah.
That's one of the ways of doing it. Which hopefully the regulatory pathway allows that.
Right.
We have a question online from Stefan Williams. Stefan.
Hey, Rishi. Nice talk. Good to see you again. I had a question. I had a meeting this morning with a guy called Tim Shaw, who's running the university's node of the digital health CRC. And he was talking about some of the challenges around data and data management in a clinical setting. You talked about sort of the watch and the computers and things. How do you find people's sort of acceptance of
Zoom is doing
data?
crazy things.
Is it? Okay, let me turn off my video. Is that any better?
Yeah, just give us 1 sec, sorry.
Sorry, I can't see a view. I can't see an option here.
Hello, Stefan Williams is talking.
If I have to go through a 5 hours,
Yeah, sorry, I can't find the option. I don't know how to turn this off.
Okay, so what I can gather from that question, sorry, Stefan.
Stefan Williams is talking.
Stefan, maybe you could put it on the chat and I can read out the question. If that's okay.
Who thought that was a good idea?
Yeah, okay. I'll see if I can.
There's a chat option.
Is it still going nuts or is it
Hello, Stefan Williams is talking. Hello, Stefan Williams is talking.
While you're typing up the question, does anyone else have one? I have a quick question. So when you mentioned the business model canvas, when I did a course at Carter, they kind of mentioned so before you start your startup, you're trying to define your total market, and then you take subcategory of that and you define your addressable market. I think there was another one, so there's some category, and it's just to sort of whittle down what is realistic in terms of you selling a product to a market, because fine.
Alert from everyone. I was just wondering if managing the data being generated by the devices is a challenge to manage in a clinical setting.
Okay, I'll do that question first. So the data generated by our device is completely de-identified. There's no subject information, so you get around a lot of things such as HIPAA and stuff like that, because you're just sending raw sets of data to a device that remains de-identified. So during our clinical trial, we don't have people's names, we don't have what's called the medical record numbers or anything of that person. That's all fine for the clinical trial. For commercial, what we might need to do is actually have the input of medical record numbers and things so that you can actually send that information to the electronic health record. So I think recently, New South Wales government, I think, just accepted a tender or put out a tender for basically getting an electronic health record, so a unified one in the hospital system. Whether or not that actually happens is, that tender's been out for a while. But the idea is everyone's moving towards these electronic health records. You basically, you plug in with your Ethernet, you send information, you use REST APIs to basically send it to those things. And at that point, we will have to deal with, I think, some privacy and confidentiality concerns there.
Hopefully that answered your questions, Stefan. If not, you can follow up. But yeah, I was going to ask.
I learned from everyone. Thanks.
Yeah, so you have the total market, and then you have like an addressable market. And when I'm looking at your device, I'm thinking, it seems like it should be used for every pregnant woman, but I'm sure there are realities here. Could you maybe talk a little bit about that?
Yeah, look, so there is a bit of a conflict between who the market is and what should that incentive market be. Because someone like me, I would say that you would use it on a high risk. Like I don't, clinicians and in general would not say that they want to monitor every single person with a CDD. It's not, there's too many false positives and things like that. So our device does help not only 50% of the population, but actually 100%, because things like postpartum hemorrhage have long-term effects on, the family, the baby, mother, also the actual hospital system itself. So I don't like doing it, but there is a cost that you can put on postpartum hemorrhage, and it is actually quite substantial in US and Australia. I can't tell you that number, but it is there. For me, I think if you're doing something a lot better than a CT, you're providing more information, more objective information, then you can maybe assist in monitoring during earlier times. But I think that's something that we need to discuss with clinicians, get their feedback on in terms of what that actually looks like, because there would be a pushback on that. I don't know if I answered the question.
Oh, yeah, definitely. All right, thank you. Does anyone else have any last questions? If not, then thank you very much again, Rishi. Thanks everyone for coming.